coordination of data to care model to systematically monitor entry into and retention in HIV care by health departments and facilities. The objectives of this module are to define retention in care, define re-engagement in care, understand the principle of data to care, and introduce a series of narrated modules on strategically using HIV cascade data to improve services across the continuum of HIV care. Just a terminology update that appeared in PEPFAR's 21 Colombian pesos. PEPFAR is replacing the term retention with the term continuity of care, replacing the term loss to follow-up with the term interruption in treatment, and replacing re-engagement in care with return to treatment. PEPFAR and WHO apply a simple definition to retention and care, that is the percentage of adults and children known to be on treatment 12 months after initiation of antiretroviral therapy. Optionally, retention can be reported at 24 and 36 months. There are other definitions of retention in care. Just to add that, in the Evaluation and Reporting Indicator Reference Guide, MER 2.5, released in September 2020, PEPFAR has replaced the terms retention with the term continuity of treatment and loss to follow up with interruption in treatment. Here we see the PEPFAR definition of re-engagement in care, which PEPFAR is now terming return to treatment. It is the number of ART patients who experienced an interruption in treatment, IIT, during any previous reporting period, who successfully restarted ARVs within the reporting period and remained on treatment until the end of the reporting period. The numerator here is the number of ART patients who experienced IIT during any previous reporting period, who successfully restarted ARVs within the reporting period and remained on treatment until the end of the reporting period. These are individuals who were previously on ART who restarted ARVs after being off treatment for greater than or equal to 28 days, and therefore experienced IIT. There is no denominator. In a systematic review and meta-analysis of 154 cohorts involving more than 1.5 million people living with HIV in 42 low and middle-income countries, retention was 78%, 71% and 69% at 12, 24 and 36 months respectively after treatment initiation. Overall, 43% of all patients not retained were known to have died. Retention of people living with HIV in care is essential for decreasing mortality and morbidity and preventing onwards HIV transmission. Retention is an important measure of program success and is a proxy for overall quality of HIV programming. Monitoring program-level retention is a critical indicator of quality of service and serves to highlight barriers to health-seeking behaviors. Retention in ART programs is a major challenge in all settings and across populations, specifically pediatric and adolescent populations, postpartum women and men. Multiple factors may play a role in loss to follow-up, including distance to health facilities, lack of transport or inability to cover travel expenses, stigma and disclosure-related issues, being too sick and lack of understanding of the need for lifelong care. Poor patient retention undermines program and patient outcomes, including achieving sustained viral suppression. The global effort to increase the number of people on ART needs to ensure that people taking ART are retained in chronic care for life. WHO recommends that the mainstays of interventions to maximize retention in care are the provision of community-based support, including peer mobilization, adherence clubs, and differentiated service delivery. Retention and re-engagement across the full cascade of care is essential to maximizing individual and population-level outcomes. Some barriers to retention in care include negative experiences of health facilities, stigma and discrimination, distrust, poor provider communication, financial issues, alcohol and substances, mental health needs, and lack of community support systems. Before moving on to interventions to maximize retention in care, let's look at some of the consequences of interrupted care. First, is HIV-related hospital admissions, in this case, admissions to a district hospital in Cape Town, South Africa. Of 600 such admissions, 209, 35.7%, patients were ART naive, 376, 64.3%, were ART experienced with 263 currently receiving ART, 45.0%, and 113, 19.3%, having interrupted therapy. So almost 20% of admissions were in those who had started ART but interrupted. Before moving on to interventions to maximize retention in care, let's look at some of the consequences of interrupted care. First, is HIV-related hospital admissions, in this case, admissions to a district hospital in Cape Town, South Africa. Of 600 such admissions, 45% of those admitted had interrupted their care and their antiretrovirals, while 36% had never started treatment. 19% were on treatment and were failing. This emphasizes the point: the most common reason for admission to the hospital in this study was not being retained in care and on ART. In early 2020, IUPAC conducted a 15-city survey to understand what activities were being implemented by the city health department, clinical service providers, community-based organizations and PEPFAR implementers in terms of retention and re-engagement in care. Here are some examples of activities in the 15 sites to improve retention and re-engagement, ranging from defaulter tracing, differentiated service delivery, community interventions, electronic SMS reminders, improved clinic services in terms of friendliness and reduced waiting times, and anti-stigma campaigns. Data to Care, D2C, is a public health strategy that uses HIV surveillance data and other data sources to identify persons with HIV who are not in care and link them to medical and social services. The use of surveillance data to identify and re-engage individuals in care is a key strategy to achieve better health outcomes for PL-HIV and to prevent new infections. D2C approaches may vary and range in scope and design and should be implemented as part of a comprehensive strategy for linkage to and re-engagement in care. It is a collaborative effort between the health department, HIV medical providers, individuals, communities and other support service providers. Data to Care uses HIV surveillance data to identify persons living with HIV who are out of care, link and re-engage them in support of the continuum of care. It is a collaborative effort between the health department, HIV medical providers, individuals, communities and other support service providers. Implementing a Data to Care, D2C, model. Data to Care is very simple concept. Logic framework. Uses clinic or health department data. Create not in care lists. Tracking and tracing. And re-engagement. Data to Care can be implemented using several approaches. Surveillance-based D2C is usually initiated by HIV surveillance programs in health departments, using HIV surveillance and other data to identify those not in care, NIC. Healthcare providers may also initiate D2C by identifying patients who may have fallen out of care and working collaboratively with health departments to investigate, locate, and relink their patients to medical care or other required services. Here is a schematic of the operational steps involved in implementing Data Care, from identifying persons not in care, investigating other databases for engaging people in care, and providing feedback to surveillance. When implemented as part of a comprehensive strategy, D2C programs can result in successful linkage to or re-engagement in care for PL-HIV, expanded partner services for PL-HIV not newly diagnosed, including an opportunity to re-interview individuals out of care, conduct partner notification, and offer testing and other prevention services, identification of and follow-up with HIV diagnosed individuals who may be in care, but are not virally suppressed, and need adherence support or other services. D2C is equally important as a prevention strategy as it is a care strategy. Ensuring that PLWH are engaged in quality HIV care improves outcomes for individuals living with HIV and prevents new infections. In this new age of messages around U equals U, Undetectable equals untransmittable. Health departments and their partners have new opportunities to help impact HIV stigma and raise awareness of the benefits of engagement and retention in care among PLWH and in their communities.